It is an honor to introduce our presenter. Dr. Kirou is an associate attending physician at the Hospital for Special Surgery's Rheumatology Department, director of Lupus Nephritis program at HSS, associate professor of clinical medicine at Weill Cornell Medical College, and associate scientist at HSS. He has 27 years of clinical experience treating patients with lupus and conducting research related to lupus and kidney issues. Lupus can affect different organs of the body at different times, including the kidneys. While not all people with lupus experience kidney disease, you may feel concerned about this potentially serious issue. For people living with lupus, kidney involvement may be silent, at least at the beginning. As such, your doctor may monitor your kidney function on a regular basis. This presentation will address these tests, the diagnosis, treatment, and research related to kidney disease. And without further ado, I would like to turn it over to our wonderful presenter, Dr. Kirou.
Hi, good afternoon, everyone. It's a pleasure to be with everybody here today. We did this, I think, about 9 years ago, and this is an update, so it's important to hear what has happened over the times. Over the years. I want to thank Roberta and Danielle for inviting me. It's very nice to be with all of our lupus patients here. Some of you are at HSS, maybe you're from other institutions, but all are welcome. I want to also say hello to my team members in research, Emily, Allison, and Romy. So with that, we're going to start. So I'm going to talk to you today about lupus and the kidneys. So next slide. Some of my disclosures. I'm participating in several clinical trials for lupus and lupus nephritis. And I might say a few words in the end about the research trials we do. Next slide. So again, remember, this is informational in general, so you get a general knowledge about the kidney and lupus, but it's not specific advice for any one of you. That you will have to discuss with your nephrologist or rheumatologist, and both of them, but I cannot give you specific advice, but in general. So next slide. So today we're going to cover a little bit about the general facts about lupus, talk about what happens when lupus and lupus nephritis starts, what is the reason for that, what are the symptoms and signs, how do we diagnose lupus nephritis, how do we treat it, what is new in terms of drugs available, and talk about a little bit the need to do more research. Okay, next slide. Okay, so as you all know, it's a disease, lupus is a disease of young or middle-aged women. 1 every 5,000 women has the disease. So this is very disproportionate to males. So 9 females to 1 male are affected. More frequently, we get this disease in African Americans, Hispanics, Asian people compared to Caucasians. 30 to 50% of patients might develop lupus nephritis. Usually starts in the beginning of the disease, the first 6 months to 3 years. Of course, there are exceptions. It might start later, so we have to be checking and monitoring for this during the follow-up of patients. Next slide. Just before we start the discussion about the disease, I want to talk about the immune system because, as you know, lupus is an autoimmune disease. Okay, so the immune system, the way it works is it will recognize foreign organisms, invaders, like bacteria, for example, or even tumors, and it will kill them, so to avoid trouble for the person, keep the person alive and healthy. So there are 2 types of immunity. One is called innate immunity. The other one is called adaptive immunity. Innate immunity is the first line of defense. It acts very quickly from the time that the body sees a foreign invader, like a bacteria, for example. Then cells like neutrophils, the white cells, go around the area and try to kill the organism and isolate it from the rest of the body. They also secrete some proteins that are very important to control this process. And these are called, for example, interferons, especially very important for immune response and defense against viruses, and also the complement system. All of these work together to very quickly kind of isolate and prevent the infection or the tumor from growing. And then it's not enough, because sometimes we need extra help to control this process, and that's the adaptive immunity. The adaptive immunity is a little more specific. It's more sophisticated. It recognizes a specific pathogen. So every infection requires a different set of cells that recognize it and then fight it. And it includes, adaptive immunity includes cells like lymphocytes. These are not the neutrophils that we talked before. These are the lymphocytes, and there are two types of lymphocytes, T lymphocytes and B lymphocytes. Okay, the T lymphocytes, they can directly kill foreign cells or make other cells be active and do the job for them. So those are B lymphocytes. They get activated by the T lymphocytes. And then what they do is they produce antibodies. So antibodies are proteins that are, again, very specific. They're targeting the specific organisms they recognize and try to eliminate it from the system. So it's like a very sophisticated weapon, you might call it. Next slide. Okay, so again, in autoimmunity, the immune system is dysfunctional, and instead of targeting infection or tumor, it targets the body itself, and we call this self-antigens. So antibody binds to substances that are called antigens, and if the antigen is within our self, this is a self-antigen. It's our own antigen. Okay, so contributing factors to autoimmunity include certain genetic mutations. Somebody is born with a mutation or variation in certain genes. Certain genes they have several variations that were done over the centuries or millions of years to fight certain infections like malaria, for example. So this is an example why some mutations, some variations happen over years to populations. So that could be a factor, the genes, genetic variations. It could be an infection that happens now. For example, somebody gets COVID-19, and maybe that triggers the immune system to react in a strange way. So that could be a factor. Again, this is not well understood exactly all the details about it, but we think it can happen. So UV light, you already know this. The sun rays can damage the skin, and by damaging the skin, expose those antigens of our body to be a target now. They wouldn't be before a target. Now they become a target because they're exposed to the immune system. So UV light and then certain drugs can trigger, again, the body to react in a strange way. And then perhaps things like smoking can also increase, or certain toxins. And this is kind of a work in progress. People still try to identify potential triggers for autoimmunity. Okay, so the antibodies that are formed against these self-antigens are autoantigens, and they can cause directly cell damage. For example, we talk about the ANA, anti-nuclear antibody, the DNA antibody, the Smith, the RNP, the Sjogren antibodies, antiphospholipid antibodies. These are all examples that you may have heard already. And they can also activate complement. Remember, we talked about this in the innate immunity slide before. So complement is certain proteins in the serum that when they get activated by the antibody, they will now trigger more inflammation. Inflammation in the joint is called arthritis. In the skin is a skin rash. In the lungs is pleurisy. In the kidneys is nephritis. So complement components that you will hear are C3 and C4, and when they get activated, they go down. And that's why their level in the blood drops, and we know that maybe something is going on. The immune system gets active, and that may be a problem for lupus. So again, doctors can rely on these tests, the C3, C4 levels, the DNA titers, and they can tell by that how active might be the lupus. Okay, next slide. So just a schematic of where the kidneys look like beans, but they're bigger, of course, and they're in the back of our body, just below the rib cage in the back. And as you can see, I don't know if you can see my pointer here. So there is something called cortex, which is this area here. The medulla is this little redder area. And so I guess the blood brings in the kidney everything, whatever is in the blood, and then the blood is filtrated here, and the urine forms. So whatever we don't need, it goes in the urine and falls down here, and the body keeps whatever it has to be kept. For example, protein. Now, in diseases like lupus nephritis, the filter here doesn't work well, and then the protein can leak into the urine, and we call this proteinuria. Next slide, please. So this is if we took a small slice from the area in the kidney that I showed earlier, we have these functioning units of the kidney. We call them nephrons. So if we take one piece of this here to see it in a little more detail, you can see something that looks like a ball. Inside the ball, there are blood vessels called capillaries because they're very tiny. So the blood comes here, and then the pressure in the blood vessel pushes the fluid outside, and that will be the urine that comes out here, follows all these tubules, and then eventually goes out. And then whatever remains gets back to the system, to our body. So this unit here is very important. It's the filtering unit, and we call it glomerulus. Next slide, please. Okay, so we talked a little bit about anatomy and function in the kidney. So again, nephrons are each individual little ball there that we mentioned and does the filtrating job. And I think we should just go to the next slide. Okay, so just now this is a biopsy. This is a real biopsy from somebody who has a normal kidney. And you can see this little ball here. This is the glomerulus. You can see empty spaces between. So this is the blood vessels and the space in between. The space between all these ball of blood vessels on the outside, this is empty area where the urine goes. And we don't see the opening, but somewhere here is an opening and takes the urine down. And around, these are the tubules. So again, remember all of these urine goes through cycles up and down until it goes out. So these are the tubules where the urine flows before it falls out. Next slide. So if somebody has protein in the urine, you can see on the top of the urine here, froth, bubbles, and that's the protein. So that's how we know there is protein. And sometimes this is larger, it looks like beer. So how do we diagnose lupus nephritis? Somebody might have high blood pressure where they didn't have any issues with blood pressure before. And sometimes you can tell that because you have a new headache that you didn't have before. There is swelling, and so that will be fluid, extra fluid that accumulates in the feet, the ankles, and sometimes around the eyes. So remember, if the kidney doesn't do a good job filtrating and sending away the extra fluid, then you get fluid in your feet. So that's how we can tell. Also, because the kidney doesn't concentrate the urine enough, you may have more urine and you have to wake up in the night to go to the bathroom. Of course, this can be due to other reasons, for example, diabetes or some other reasons for that, or bladder issues. When the bladder doesn't function well, you may also have this issue. So it's non-specific. The frothy urine we already talked about. Sometimes the urine becomes a little brownish because there may be a little blood there. But it's very important to remember, sometimes there is no symptoms. So therefore, it's very important that the physician, or the rheumatologist, or the nephrologist does a urine test so they can check whether there is protein or blood in the urine. And of course, if there is something like that, there is blood in the urine, it doesn't mean necessarily that it's lupus nephritis, right? It could be a kidney stone, UTI, menstruation, and so many other things. So we have to really make sure that we interpret the findings well to be sure it's due to lupus nephritis or something else. Next slide. Okay, so what are the basic tests we use when we try to assess how is the kidney working? Creatinine, which is it's a waste product, actually. It's formed in the body and then it can be out. Is very important because it can tell us the function of the kidney. Normally, creatinine is below 1 milligram per deciliter in an average woman. It may be a little higher in somebody who is very muscular. So 1.2, 1.3 might be a normal finding in somebody who is muscular. Now, if somebody is very tiny, though, this could be, you could expect this to be 0.4, 0.5. So it has to do with the muscle mass as well. Okay, so albumin is one of the most important proteins in our blood. And if we keep it in the blood, it helps keep the fluid inside the blood vessels. If we lose it in the kidney because the kidney doesn't filtrate well, then it drops in the blood, so it becomes less than 3.5. And then it doesn't keep the fluid in the vessel. The fluid goes out in the ankle and foot, and then we have the swelling that we talked about before. The electrolytes are important to know, the sodium and the potassium bicarbonate. These are important to know. The potassium may go high in somebody whose kidney doesn't work well. And another term that you will see is the glomerular filtration rate, eGFR. And this is something calculated from the creatinine, the age, the race, and the gender. Normally is between 81 and 120. This normally falls. Somebody who is normal, completely normal, but it's 80 years old, this GFR may drop to about 60 or 50 and it still be okay. But it may drop with kidney disease from any type, and including lupus nephritis. Next slide. Okay, in the urine test, we look for protein, we look for blood, like red cells and white cells, and normally they have to be below 5. Anything above that might be an indication of something is wrong. And we also sometimes need to measure a 24-hour urine collection because it's more accurate to quantitate the protein level. Sometimes we can also do that by doing a spot urine analysis. It's not as accurate, but it's acceptable in many cases. And then we do sometimes a kidney ultrasound to measure the size of the kidney and see how the kidney looks, if it looks healthy or not. And then we do a kidney biopsy. Next slide. So now in terms of the immune system, we need to know how the immune system works. The C3 and C4 we talked about, these are the complement levels. They normally, C3 above 80, C4 above 16 or 12, depending on the assay you do. But if it goes down, it may mean that the lupus is active, the immune system is active. The DNA normally is absent, but the nDNA level can go up in high activity of lupus disease. Antiphospholipid antibodies sometimes are present, and they may increase the risk of somebody to get a blood clot. They don't always do that, but sometimes they may be responsible for blood clots in the body. Other important tests we do is the vitamin D, because that protects our bone, and the immune system gets better when the vitamin D is normal. We don't want it to be too high either, so between 30 and 50 is a good number. The parathyroid hormone tells us again how is the bone status, and we want to keep it at normal levels or reasonable levels. The bone mineral density is something to tell us about osteoporosis. So this is like an X-ray we do when somebody takes steroids, so that we can be proactive and supplement calcium, vitamin D, and if sometimes we need to do medication to prevent or treat osteoporosis. Next slide. Other tests when you have a kidney problem, and especially when the protein in the urine is too much, then the cholesterol goes up, and cholesterol means cardiovascular disease. So we want to know about this, and we want to treat it. We want to also know the sugar levels, especially if somebody has diabetes and they take steroids, the sugar can go up, and we need to control that. Hemoglobin is important to know because anemia is not uncommon in patients with lupus and inflammation, or especially if there is something else like hemolysis, which is the breakdown of blood vessels because of lupus. That's a more serious disease manifestation. The white count may go down if somebody takes too much medicine, for example, cyclophosphamide, which is a chemotherapy treatment. If somebody takes too much, the white count may drop, and that may predispose to infection. So we want to know this number as well. The platelets are important for us to know what is the risk of bleeding. If they go too low, somebody might have higher risk of bleeding. So sometimes this goes down because of lupus or medication. And we need to know if somebody has been exposed to tuberculosis, they have a positive quantiferon test, if they have been tested for hepatitis C and B or HIV, because these will affect our decisions about how to treat with immunosuppression. Next slide. The kidney biopsy is important for us to confirm the diagnosis of lupus nephritis and exclude things like toxicity of drugs, dehydration, and other reasons. It also tells us about the type of nephritis. We call this class of lupus nephritis because therapy might be different depending on what we have as a class of nephritis there. We also want to exclude thrombotic microangiopathy, which is small blood clots in the kidney. We want to know exactly how much inflammation is there in the kidney, because that's something we can do. We can resolve it. We can make it go away with medication. Versus how much scarring, because sometimes scarring is not treatable. So if everything is due to scar and not inflammation, we may want to cut down on medication and find other ways to treat the disease. Okay, so we also may repeat a kidney biopsy if we feel that things are not going well. We may want to do it again. So again, we think that we want to do a kidney biopsy to somebody who has significant proteinuria. Like if the protein level in the 24-hour collection is more than 0.5 to 1 gram per 24 hours, then that's significant enough to want to do a kidney biopsy. Normally, the protein in the urine is 0.2 or less. So 0.5 or 1 are abnormal. When it's too much and you get fluid in the legs, usually goes above 3.5 grams. Next slide. So these are the different classes of nephritis, and that information we get with the biopsy. Class 1 is minimal disease. You have only very mild evidence of inflammation in the kidney. Class 2 also minimal. So let's not talk about those. Are not so important. Class 3 and 4 is it's important. It's focal and diffuse lupus nephritis. We have many cells within this little ball of blood vessels I showed you earlier. So many cells flood this, and it becomes congested, and it becomes altered in a way that it doesn't work well. And class 5, we don't have this congestion in the little ball of glomerulus, but something else happens. The wall of the vessels becomes very thick, and when it becomes very thick, it becomes more difficult for the filtration. So I guess membranous disease, class 5 and 3 and 4 are a little different, but they can coexist in the same person. So we want to know about those as well. Class 6 is when I guess now everything is scarred and we don't have a lot of inflammation. So we have to kind of withdraw immunosuppression and treat otherwise. Next slide. So now, we can see on the left side what you already saw before with a normal kidney, but on the right side, you see now that it looks congested, right? We don't see the empty spaces in between. Now we see a lot of cells, compact structures in here, and that, I guess, is inflammation, and that is what doesn't allow the kidney to work well and filtrate the urine. Next slide. Another slide. This one shows you immunofluorescence, meaning that we have taken the biopsy of the kidney. Now we're trying to see whether there is deposition of antibodies on the kidney tissue. And this green stuff is antibodies that are now on top of the kidney. And these are the reason why the inflammation happened and why we have all these other cells that flooded the kidney. So that's an indication of, this is an autoimmune process. We have all these antibodies depositing in the kidney. Next slide. Okay, the disease course. So sometimes it's the first sign of lupus, but it can happen later. It may. Lupus nephritis, unfortunately, is not something that you get once, you treat it, and it goes away. It may go away, but it may come back. So it's a relapsing disease. So we have to always keep an eye on it. And again, if you keep having attacks, every time you have an attack, you have some more damage happening in the kidney, some more scarring. And if you keep getting those, that's a problem because you may lose function and you may get to this class 6 of nephritis, which we cannot really reverse with our treatments. Next slide. Okay, the treatment of lupus nephritis, we kind of think about it in two ways. Initial treatment, when we want to make things quiet down, all the inflammation, and then maintenance, where we're going to keep everything controlled. So in the initial therapy, that usually happens in the first 3 to 6 months of the disease. We use steroids. Steroids are good and bad, right? So they're good in the beginning because they work very quickly. They control inflammation very well. They make you feel better. And we try to do that in the beginning, but we want to taper them off slowly while we add other medications because they can have side effects if somebody keeps taking high doses of steroids for a long time. So we want to do it the right way, smart way. So we add early on something else, and that would be either chemotherapy, cyclophosphamide, which is done by IV in the infusion room every 6 months. And it could be high dose or low dose. And that is a decision that the doctor can make with the patient. Or you can do an oral medication, which is the most common we use is mycophenolate. So this is a pill you take. Sometimes people have to take 6 pills per day, depending on the weight of the patient and how serious is the disease. So again, if somebody cannot tolerate the oral medication because they have diarrhea or they have stomach pain, then we have to go to the IV. So it kind of varies also with the patient, what reaction they have to medications. Sometimes, if their cases are difficult to control, we can use something else called tacrolimus or cyclosporin. Sometimes we do use rituximab, which is another infusion. This is not as bad as chemotherapy. It's not as strong. It doesn't cause so much nausea, or the risk of infection is less. And then that can also be a help for us. Next slide. The subsequent, so after we achieved remission or good control of the disease, so now we're going to keep it there. So we still use sometimes low dose steroids, let's say 5 milligrams of prednisone, or we try to go off steroids completely. So, but we still need to do some of this oral medication, the mycophenolate, or if people don't tolerate that or have a contraindication to mycophenolate, we use azathioprine, which is another pill. Next slide. Potential side effects, so steroids can cause weight gain. I tell my patients to, if they take steroids, to weigh themselves, if not every day, at least every twice a week, once a week, make sure that they have it under control. Because it increases your appetite, it makes you eat junk food, so you want to be careful about that. It can also increase the blood pressure, so we have to be careful to check the blood pressure. It can cause osteoporosis, but this happens usually if you take it for several months. We want to start, if somebody has no contraindications, so protection for osteoporosis, for example, with something like alendronate. Osteonecrosis is when the bone suddenly gets very painful. Usually the hip gets painful, and it may be sometimes more serious to the point that in the more severe cases, somebody might need to have a replacement of the hip. If it's really bad. The adrenals, that's organs in the body that produce steroids. So the steroids we produce ourselves all the time, but if we take it by outside, by mouth, then the body gets lazy, doesn't produce it. So in that case, we have to very slowly taper the steroid off so that we allow the body to take over. Okay, so cyclophosphamide is the chemotherapy we mentioned earlier. It can cause nausea, headache, infection sometimes. So we always measure the white count to be sure we are okay. For young people, we kind of worry about infertility. So we try to use sometimes the low dose cyclophosphamide for those patients. It can cause hair loss, and we don't use it in pregnancy because it's toxic. Mycophenolate is the oral pill. Again, we don't want to use it in pregnancy. Somebody wants to be pregnant, it may be teratogenic, so we don't want to use it. And we already mentioned side effects like diarrhea, nausea, low counts. Azathioprine, very similar to mycophenolate in side effects, but is safe for pregnancy. So that's an advantage for that medicine, and we can use it. Same thing for tacrolimus and cyclosporin. It can be used in pregnancy if needed. Rituximab, generally tolerated well. It has been a problem in the pandemic because people were new to COVID-19 infection, and that this medicine doesn't allow them to get antibodies with the vaccination. So people who might have been vaccinated, but if they were on Rituximab, they didn't get enough protection. So that's an issue there. But in people who are already vaccinated and we know it works, actually it's a good drug. And when we really need it for somebody who is really sick, that obviously overpowers the decision to use it because we want to make people better at that setting. Next slide. New drugs. So now we have some new drugs for lupus. Anifrolumab. It's something that targets. So it's a very specific. Now remember, the antibodies are very specific. They're very sophisticated weapons. This is another one like that, but this is made in the lab in the pharmaceutical company in these days. So it was tested and it showed to be very active for lupus. So it targets the interferon that we mentioned before. Interferon is something that protects usually from virus, but in lupus is too high for no good reason. So by blocking interferon in this situation, we make the disease better. Again, people who took this drug in the study, they had shingles. So we want to vaccinate. So now if somebody wants to go in this medicine, they have to be vaccinated for COVID, for shingles, to be on the safe side. But otherwise it's tolerated well, it's effective, especially for the skin. Now for lupus nephritis, we don't know yet. It's under study. It shows promise, but we don't know yet. It's not approved for lupus nephritis yet. Obinutuzumab is something like rituximab, but it's stronger, and its preliminary results show that this will work well for lupus nephritis, but we're waiting for the results of the phase 3 study. So we'll see. Next slide. I forgot here for some reason to mention another drug called voclosporin. Voclosporin is like cyclosporin or tacrolimus in the same category, and voclosporin is a pill, but it's approved for lupus nephritis. So unfortunately, somebody might need to take again 6 pills. Depends on the person, obviously, to control the disease. We use voclosporin in somebody who takes mycophenolate, but is not 100% well yet, and we need additional help. So we may use voclosporin for that reason. Again, it's an FDA-approved drug. For some reason, I forgot to put it here, but it's another good option for people with lupus nephritis. So additional therapy. So in addition to controlling inflammation in the kidney, we can do other things. We use something called lisinopril, an ACE inhibitor, or losartan. It's an angiotensin receptor blocker. These are blood pressure medications that can protect the kidney mechanically, meaning they don't allow the protein to go out of the filter, in the urine, so they work in a different way than the other drugs, and these are helpful. We often use these drugs with, obviously very carefully, not to cause trouble. And then we have some new drugs that are approved for diabetes, for example, dapagliflozin, and other in the same family. They protect people that have some chronic kidney disease. So somebody who has lupus nephritis, they may have a little bit of a chronic kidney disease, and this will protect the kidney so that the kidney is lost and we don't need any transplants or hemodialysis to do. Again, these are new. And then we sometimes use them in addition to the other medications. So every little thing helps, basically. We use water pills, diuretics, to control the fluid swelling. And we use other drugs for blood pressure if the blood pressure is not controlled with these medications. Next slide. So for the bones, we need to take calcium, vitamin D, and sometimes we need to also use alendronate if somebody already has osteoporosis. Statins like atorvastatin or rosuvastatin used for high cholesterol. And then sometimes we use blood thinners for somebody who has antiphospholipid syndrome, or they have too much protein in the urine, because sometimes this increases the risk for blood clots. And we need to think about vaccinations to prevent infections. Next slide. So also we need to do some lifestyle changes. Hydrate, drink a lot of water, at least 2 to 3 liters per day is probably a good idea. Low sodium diet for people, especially who have hypertension and swelling of the legs. Low potassium for people who have high potassium, or they have issues with the kidney function. Exercise, if your doctor has no objection to that. Stop smoking and alcohol. Monitor the blood pressure. Check your weight regularly. And avoid NSAIDs, and avoid ibuprofen, naproxen, meloxicam. All of those drugs can affect the kidney, so we don't want them, especially if we have already some kidney problem. And then if we need to get a CT, a CAT scan, for example, for some other reason, we want to avoid the dye, because that can damage the kidney if our kidneys do not function well. If the kidney functions well, there's no problem. Next slide. Pregnancy can be a problem because it's a risky period for somebody with lupus to get worse, especially if they have very active lupus nephritis. So we wait for 6 months at least to make sure the lupus and the lupus nephritis is under good control before we allow somebody to safely get pregnant. And of course, we try to change our medications so that they're not toxic for the embryo. Next slide. Chronic kidney disease happens sometimes, unfortunately, especially if somebody has multiple attacks of nephritis. Creatinine goes up to more than 2. The GFR goes below 50. And you may have things like more anemia. The parathyroid hormone may go up, and that may be a problem for the bone. The blood pressure may be more difficult to control. You may have atherosclerosis, so you want to check your heart, go to the cardiologist, and follow up with regularly with your kidney doctor. And sometimes if things go wrong, go in the wrong direction, some patients, a minority, will need to go on dialysis or get a kidney transplant, even better. If that's a very good option also. And that things, kidney transplants are I guess God sent gifts to us because they can change life back to normal. Of course, you take medicine, but things are much better. Next slide. So the future of the management of lupus nephritis, again, despite the new promising agents, we still have a long way to go to improve lupus nephritis outcomes. We're still not there, so we need research. And I guess we need to do research, especially for people who have more severe disease and they may have more severe nephritis. And these include African Americans, Hispanics, Native Americans, Asians. So we want to include these people in the trials and make a difference. Next slide. So what are types of studies we do in lupus. So we do collect questionnaires. Some of you already have seen this. Our research coordinators will give you questionnaires to fill out, and then we'll see, by that we'll gain information about your health and how things are going. We observe people, we do tests, we collect samples. So that will be repositories and registries we have at HSS also. And then we have interventional studies. These are the studies where we give medication to see if we can get better in the treatments of lupus. And that could be either through NIH, the National Institute of Health, or certain pharmaceutical companies. So we are part of the an investigators network called LUCIN, Lupus Clinical Trials Investigator Network. And we do also studies in lupus and lupus nephritis here at HSS. Next slide. And again, before a drug can be approved, like remember the new drug anifrolumab, it goes through a preclinical phase where they tried first in animals. Then we tried in phase 1 and 2 studies in a limited number of patients to see if it's safe and see what dose might be effective. Then we go to phase 3, which is the large study before something is approved. And finally, we still watch people after they finish the randomized trial. We make sure everything they're still safe to continue these drugs and still effective. Next slide. So why somebody might not want to do a research? There some, I know people are busy, they have family obligations, professional, and so on. Some patients might be concerned about safety because they don't know what's the new drug, or others the opposite way. They want to get the active drug. They don't want to get the placebo because these are studies where we randomize people to one or the other, and we don't know who gets what, or people are not aware about how is research done, and lack of access to research centers. So I guess we and I guess others in the network, we are very careful to do the studies in a safe way. Next slide, please. To follow all the protocols. There is an IRB who oversees the conduction of study to be safely conducted, and so on. Benefits for the people to participate in the study is because we may benefit from a new drug, right? That's safe and effective, and also the community. That's very important, so that if we don't do the studies, we don't know, right? So then we're not going to have new drugs approved. So we need to do that also for the general good of lupus patients. And then people who participate, they usually are better because they come to studies, to the visits all the time, and they're probably doing better just for this reason, because they're more adherent to the visits and the drugs and everything. And then there is a close collaboration, a physician and research team and the patient, and that, I guess, teamwork sometimes makes things better. Next slide. Okay, so take-home message: partner with your rheumatologist, share concerns and questions. See also your nephrologist, the kidney doctor, involved in your care, know your numbers, and select the best drug for you after you talk to your rheumatologist. Know all your pills. Very important to write them down, understand what they are for, how to take them, and use pill organizers, and so on. Next slide. And again, some signs of disease to recognize. Again, the swelling of the feet, the high blood pressure, the frothy urine, fever, joint pain, skin rash, side effects of the medicines. Remember, this could be diarrhea, fevers if you get an infection. Remember to take care of your bone and your cardiovascular, and consider a clinical trial if you can. Next slide. And here I want to thank you. So from our lupus nephritis program at Special Surgery, we are part of the Lupus Center of Excellence, and we work together with NYP Cornell, and you can see the team members of our research here at HSS, and Emily is actually in this call, and you have her number there and email. And thank you very much. Any questions now?
Thank you so much for this excellent presentation, Dr. Kirou, and we will now be ending the recording.